Let's make a quick review of cell injury, cell adaptation, and cell death. So let's start with adaptation. And the first thing that I need to mention is hypertrophy. Hypertrophy means an increase in cell size. The classic example is the heart. Cardiac cells cannot divide, so when there is increased workload, they grow bigger. Hyperplasia. Hyperplasia is an increase in the number of cells, and a good example is the endometrium, which proliferates in response to hormones. Now, very important, hyperplasia is not cancer, but some types, like endometrial hyperplasia, can progress to carcinoma over time. Third, atrophy. Atrophy is a decrease in cell size. Cells become smaller, often due to decreased workload, reduced blood supply, or loss of stimulation. Remember that when a cell undergoes atrophy, the main mechanism of protein breakdown is the ubiquitin proteasome system. Now, another adaptation is metaplasia. Metaplasia is a change from one cell type to another from the same germ cell layer. It is an adaptive process, usually in response to chronic irritation. For example, in smokers, normal respiratory epithelium can change to a more protective squamous type. Another good example of metaplasia is the Barrett esophagus. Now, mentioning injury, reversible and irreversible, is the key question when you have an injury. So let's make a quick review of the morphologic changes that we need to remember about both types of injury. For the reversible injury, in this case, as you know, the cell is damaged but can still recover. So the main change is cell swelling due to loss of ion balance, and you also see dilation of the endoplasmic reticulum, and that dilation will lead to ribosome detachment, so protein synthesis decreases. If the injury continues, it becomes irreversible. At this point, the cell cannot recover and will die. The key features are mitochondrial damage, loss of membrane integrity, and calcium influx. Remember that calcium influx is a main and powerful activator of destructive enzymes. So it is very important in the development of an irreversible injury. In the nucleus, you can see some changes like pyknosis, cheirolysis, and chirorrhexis. Now, talking about ATP depletion, and let's see what happens when ATP is depleted, especially in ischemia. First, the sodium potassium pump fails because it needs ATP to work. As a result, sodium and water enter the cell, and the cell swells, and we have edema in the cell. Second, the cell shifts to anaerobic glycolysis, and this process will produce lactic acid, which lowers the pH and causes acidosis. Third, protein synthesis decreases, and this happens because ribosomes detach from the rough endoplasmic reticulum. So those are the main changes that you will have when you have ATP depletion. Now, talking about free radicals. There are many types of free radicals, but I want to make some emphasis in the ROS, reactive oxygen species, and the NAPQI because it is highly testable. So when we go to the ROS free radicals, remember that you have a number of them. Superoxide, hydrogen, peroxide, and hydroxyl radicals. They are mainly produced in the mitochondria during normal metabolism, but they increase a lot also during stress or during inflammatory processes. A classic situation related to this is the reperfusion injury, when oxygen suddenly returns to ischemic tissues and generates a burst of ROS. These molecules are very reactive and damage cell components. They cause lipid peroxidation of membranes, protein damage, and DNA injury. Another important example is the NAPQI from acetaminophen metabolism. If glutathione is depleted, NAPQI accumulates and leads to hepatocyte necrosis. Okay, so this is something important to remember again. Now let's focus on reperfusion injury. During ischemia, the problem is lack of oxygen. ATP decreases, the ion pumps fail, and the cell starts to swell and become acidic. But interestingly, the real damage often happens when blood flow returns. With reperfusion, oxygen suddenly re-enters the tissue, and this leads to a burst of reactive oxygen species, or ROS. These ROS are highly reactive and cause damage to membranes, proteins, and DNA. At the same time, mitochondria become dysfunctional and inflammatory pathways are activated, which amplifies the injury. So, reperfusion injury is something that you need to remember. Now, regarding necrosis and apoptosis, necrosis is uncontrolled cell death. It usually affects groups of cells and it causes inflammation because the cell membrane breaks and contents leak out. In contrast, apoptosis is programmed cell death. It typically affects single cells and there is no inflammation because the cell membrane remains intact. In necrosis, cells swell and eventually rupture, and necrosis have inflammation. This is a major difference between necrosis and apoptosis. Necrosis have inflammation, apoptosis don't have inflammation. And apoptosis, we don't have a rupture of the cell. In apoptosis, cells shrink and break into small, well-defined fragments that we call apoptotic bodies. Now let's look at the nuclear changes in necrosis. First, we have pyknosis. This is shrinkage of the nucleus and it becomes dark and condensed. Second, karyorrhexis. This is the fragmentation of the nucleus into small pieces. And third, we have karyolysis. This is dissolution of the nucleus where it progressively and quickly fades and eventually disappears. If we take a look to coagulative necrosis, this is the most common type of necrosis and is typically caused by ischemia. The key feature is that the tissue architecture is preserved, at least initially, so you can still recognize the outlines of cells even though they are dead. The major exception for coagulative necrosis is brain, where ischemia leads to a different type of necrosis called liquefactive necrosis. So if we take a look to the cells in this image in the left, we can see normal myokaryocytes. And here in the right, we can see necrotic myokaryocytes. And if we take a look, for instance, to this myokaryocyte, one of the most important things is that you can see a nucleus. There are no nuclei, but we can identify the structure of the tissue. Okay, so the main feature of the coagulative necrosis is preservation of the outline of the tissue, preservation of the architecture of the tissue. So that helps a lot to distinguish coagulative necrosis from other types of necrosis. Now, in this case, we have a liquefactive necrosis. And the key feature here is loss of tissue structure. You can recognize nothing from the original tissue. Okay, and this is the most important thing in this situation. The tissue is completely digested and becomes soft and liquid. In coagulative necrosis, we have a firm tissue. In this case, the tissue is soft and liquid. Okay, and this happens because enzymes break down the dead cells very quickly, leading to a massive destruction of the tissues involved. The classic example is the brain after ischemia. We can see leukocytic necrosis also in severe bacterial infections. I'm talking about abscesses, where neutrophils release enzymes and form pus. We have here a caseous necrosis. And remember, the caseous necrosis can be seen in many granulomatous disease, fungal diseases also, but is classically seen in tuberculosis. And the necrosis is associated with granuloma formation. The key feature is a soft, white, cheese-like appearance in the gross image that we have here on the gross findings, and microscopically you will see a central area of amorphous debris. We don't see nothing here, loss of structure, and this usually is surrounded by inflammatory cells, as we can see in this area. And the inflammatory cells formed what we call a granuloma. So caseous necrosis is something that you should consider when you have a patient with tuberculosis. Now we have here fat necrosis. This typically occurs in acute pancreatitis or often trauma to fat tissue. The key mechanism is the release of lipases, which break down triglycerides into free fatty acids. These fatty acids then combine with calcium, forming chalky white deposits, and the process of formation of this type of deposits is called saponification. So histologically, you see necrotic fat cells with these calcium deposits. We can see here macroscopically, we can see the chalky white deposits in this over the abdominal wall and the bowel wall also, and we can see here pointed by the arrow in this area fat necrosis. Please let's call this area 1 and let's call this area 2. Please compare the features of the adipocytes in area 1 and area 2. Area 2 are normal adipocytes and area 1 are necrotic adipocytes. So we have fat necrosis here and we have normal adipocytes here. The adipocytes in area 1 looks like a ghost. So we talk about ghost adipocytes, and this is a classic description for pathologies about fat necrosis. Now, let's talk about gangrene. Gangrene is not a specific type of necrosis, but a clinical term. There are two types of gangrene, wet and dry. Dry gangrene is caused by ischemia. It is essentially coagulative necrosis, typically in the extremities, and the tissue appears dry and black. And when wet gangrene occurs when there is a superimposed infection. In this case, bacteria cause liquefaction, so the tissue becomes swollen, soft, and foul smelling. So there are radical differences between both types, and you can see that you have in general loss of the structure of the architecture of the tissue, and you will see at the same time a massive inflammation mainly composed of neutrophils in cases of gangrene. Okay, now we'll talk about apoptosis. Apoptosis, as you know, is programmed cell death, meaning it is a controlled and regulated process. It usually affects individual cells, not groups, and the key feature is that there is no inflammation because the cell membrane remains intact. So remember again, apoptosis causes no inflammation and necrosis is an inflammatory process. In case of apoptosis, the cell shrinks, as you can see here. We have a reduction in the size, okay, and the nucleus condenses and the cell breaks into small fragments called apoptotic bodies, and the apoptotic bodies will be quickly removed by macrophages. Okay, so this is another important thing to remember. We have here in the histologic slide this structure, and this is an apoptotic body. When you have something like this in a question or an histologic site, think in apoptosis, apoptotic bodies. Now, if we're talking about apoptosis, we need to talk also about caspases. Okay, caspases are the enzymes that drive the apoptosis. They are divided in basically two types: initiators and executioners. Okay, and depending of the pathway, we'll have different caspases. There are two pathways for apoptosis: extrinsic and intrinsic. Okay, caspase 9 is part of the intrinsic pathway, which is the mitochondrial pathway. This is another name that we have for the intrinsic pathway, mitochondrial pathway. Caspases 8 and 10 are part of the extrinsic pathway, which is triggered by death receptor. Okay, so caspase 9, 8, and 10 are part of what we call initiators caspases, and caspases 3, 6, and 7 are part of what we call the executioner caspases. Caspases are responsible for breaking down cellular components and leading to the cell death. So this is a simple thing, but you need to remember that. Now, let's look at the intrinsic pathway of apoptosis. This pathway is triggered by internal stress, such as DNA damage, hypoxia, or endoplasmic reticulum stress. The key event here happens in the mitochondria. Remember that under stress or injury, pro-apoptotic proteins like BAX and BAC are activated, and they increase the permeability of the mitochondrial membrane, blocking BCL2 and BSE-LXL that are anti-apoptotic proteins. As a result, cytochrome C, which is normally inside the mitochondria, is released into the cytoplasm. Cytochrome C then binds to APAF1, a protein that is in the cytosol of the cell, and forms the apoptosome complex. And this complex activates caspase 9, and caspase 9 then activates executioner caspases like caspase 3 mainly, which carry out cell death. If we move into the extrinsic pathway, we have something different. This pathway is triggered by external signals and is frequently associated to viral infections. This is something that you need to remember because this is the way to introduce extrinsic pathway in exams. A viral infection, hepatitis B, hepatitis C, something like this. So it starts when fast ligand or TNF binds to death receptors on the cell surface, and this will form something called FAT. Okay, this activates adaptor proteins and leads to activation of caspases 8 and 10. Remember, 8 and 10 are initiator caspases, and they then activate executioner caspases like caspase 3, and that leads to apoptosis. So different mechanism to make apoptosis the extrinsic pathway. In this slide, we have a summary of what we call non-necrotic cell death. So we have the extrinsic and intrinsic pathway of apoptosis and also necroptosis. So let's make a quick review again of apoptosis. Okay, first, the intrinsic pathway. It is triggered, by internal damage like DNA injury or hypoxia. This activates backs and back, blocking BCL2 and BCLXL proteins in the mitochondrial membrane. That leads to release of cytochrome C. Cytochrome C activates caspase 9 mainly, and then caspase 3, resulting in apoptosis. Okay. Second, we have the extrinsic pathway. This is triggered by external signals like Fas ligand or TNF binding to death receptors. This activates caspases 8 and 10, which then activate caspase 3, leading to apoptosis. Now, necroptosis. Necroptosis is different. It also starts with death receptors, similar to the extrinsic pathway, but instead of activating caspases, it activates proteins like RIP1 and RIP3. This leads to loss of membrane integrity and cell rupture. So the cell dies in a way that resembles necrosis with inflammation. We have here these rectangular cells. Okay, and they are typical of cardiac muscle cells, and in cases of hypertrophy, they are more prominent. Okay, in these cases, the nuclei become enlarged and take on that rectangular shape due to increased DNA content. So when we see this type of change, we call this the boxcar nuclei. So when you have or you see a description of boxcar nuclei, think of cardiac hypertrophy as we have in this image. In this image, you can recognize myocardium by this nuclei, and at the same time, some cells have lost their nuclei, which indicates a few necrotic fibers that is common finding sometimes, and that's why we develop hypertrophy as a compensation, as an adaptation to the problem. Okay, so remember boxcar nuclei. In this case, we have a squamous metaplasia. Probably this patient is a smoker, and we can see a squamous epithelium all around in this area, in the bronchial mucosa, in this lung. We know that this is lung because we can see here alveoli. And in this other image, we can see alveoli all around this area. And we can see how this epithelium change. If you take a look, you can see the microvilli here in this pseudostratified columnar epithelium in the bronchial mucosa, but suddenly it changes to this squamous epithelium, especially in this area, which is pointed by the arrow. Here we have again pseudostratified columnar epithelium, but this area, I will highlight this in yellow. We can see this. Let me erase all this, and we go back to again highlight the specific area. This one here. You can see the change from this type of columnar epithelium here to a squamous mucosa in this area. How now we have here specifically uh, metaplastic change. So this is metaplasia. Okay, this happens in response to chronic irritation like smoking. The new squamous cells are more resistant to injury, so it is a protective change. But on the other hand, you lose important functions like mucus production and also ciliary movement. Okay, the mucus escalator is lost in this area, and if the irritation continues, it can progress to dysplasia and eventually cancer. And why we can uh, uh, have cancer in cases of metaplasia? Because in order to produce metaplasia, cells needs to have a reprogramming. We need to make a reprogram the genetics of the cell. We need to change the genes of the cell. This is necessary to produce a different type of cell. So that's why we can have a cancer easily in cases of metaplasia. Remember, metaplasia is not a precancerous lesion. It is just an adaptation, but it's easier to have cancer in cases of metaplasia than any other type of adaptation. We have here another important metaplastic change. This is the Barrett esophagus. Normally, the esophagus is lined by a stratified squamous epithelium, as we can see here. Okay, in this area, this is the normal epithelium of the esophagus. This is squamous. But in Barrett esophagus, this is replaced, as we can see here, from here to here, by columnar epithelium with goblet cells. And this is mainly due to acid reflux. So this is a type of metaplasia. The new epithelium is more resistant to acid, but it is abnormal for dislocation. And importantly, Barrett esophagus also increases the risk of esophageal adenocarcinoma. We can see here again a type of necrosis. This is clearly the structure of the tissue clearly points to cardiac tissue because of the shape of the cells. We can see some cross striation that help us to identify muscle, as we can see here, this cross striation that says that this is muscle, but we can see any nuclei inside the cells. So those are necrotic cells, but we see preservation of the structure. So probably you are thinking that this is coagulative necrosis, and yes, you're right, this is coagulative necrosis. Here in this case, we have liquefactive necrosis. This is brain. This slide corresponds to brain, and we can see here in the cortex of the brain this tissue that have loss of the normal architecture. Okay, and this type of necrosis is what we call liquefactive necrosis. So loss of a structure is found in the brain, especially, or in an abscess, or inside the pancreas, points to liquefactive necrosis. Now we have here this another different type of necrosis. We can see a central area with necrosis, complete loss of a structure, and this area is surrounded by inflammatory cells, mainly lymphocytes and also macrophages. And take a look to this important cell that we have here inside. This one. This is a giant cell. This is a giant cell that we find in some cases of caseous necrosis. This is the Langerhans cell. Langerhans cells are seen in cases of tuberculosis. Okay, so in this case, we can describe these findings as a central area with complete loss of structure, and you will see that the necrotic center is usually or is surrounded by granulomatous inflammation composed by giant cells, multinucleated, giant cells, macrophages, and lymphocytes. Remember that when we have this type of granulomatose processes, macrophages join together, many macrophages join together, forming these giant cells trying to engulf more and more and more cells. We have here apoptotic bodies, and we can see here a big apoptotic body here. Probably here's another one, here's another one. They are small, round, eosinophilic fragments of cells. They represent cells that have undergone apoptosis and broken into pieces. Each fragment may contain nuclear material of cytoplasm, nuclear material or cytoplasm, and importantly, they are quickly removed by macrophages, so there is no inflammation during or after an apoptotic process. Now, finally, this is a common cause of confusion, and I want to make clear the histologic differences between adipocytes, fatty changes, and fat necrosis. First, adipocytes, cells that we have here. Those are adipocytes, okay? Adipocytes are normal fat cells. They have a large, clear back wall that pushes the nucleus to the periphery. So this is the nucleus, okay? This is the nucleus of another one. This is the nucleus. So, another here. So remember, adipocytes have the nucleus located in the peripheral part. And why we have the nucleus in the peripheral part? Because adipocytes have a massive back wall, okay, that pushes the nucleus to the periphery, okay? So to identify a normal adipocyte, you will see one big empty space with a thin ring of cytoplasm, which is this one that I'm moving the line around the cell. So this is the adipocytes. Second, fatty changes. Those are the fatty changes. Another name that you use for fatty change is steatosis. This is intracellular fat accumulation, usually in organs like the liver. The key difference is that the fat is inside the cell, not a separate fat cell. So in this case of these fatty changes, we don't have adipocytes here. This is hepatocytes, cells of the liver that have small vacuoles filled with fat. Okay, the vacuoles can be unique or multiple. Sometimes the vacuole can be large, but the nucleus is still part of the same cell. And third, we have the fat necrosis. Here, this is the fat necrosis. We already see this image. This is destruction of fat tissue. The cells lose their normal structure, and you see irregular ghost-like outlines. And you may also see, in some cases, not seen in this image, inflammation and calcium deposits. So this is the main distinguishing features between adipocytes, fatty changes, and fat necrosis. Thank you very much.